هلا unmute.
You unmuted yourself.
بس هلا شو اسمه؟
Hello, colleagues. This is Asmus here from EMRO. Can you hear me, please?
Yes, we can hear you, Doctor. Can you hear us? Dr. Asmus?
Sorry, yes. Now you can hear me again?
Yes, yes, we can hear you.
Perfect. Thank you very much.
Hello, colleagues. Can you hear me? This is Dr. Hiba Fuad from EMRO.
Yes, we can hear you, Dr. Fuad.
Thank you. Just want to make sure that you received my slides and you can run it from your side, please.
Yes, we have received them. When it's time for your presentation, I can run it and give you control to flip the slides from your side.
Okay, that would be great. I sent 2 copies and the last version, I think it's the updated one. Thank you.
Yes.
Thank you. Thank you.
Hello, everyone. Dear Adriana, Vinayak, Asmus, friends and colleagues across the globe, good day, wherever you are. On behalf of the organizing committee, welcome to the 4th International Congress on Waterpipe Tobacco Smoking. It has been 4 years since we held the 3rd Congress in 2018, when the Knowledge Hub on Waterpipe Tobacco Smoking was launched at the American University of Beirut as a joint project with WHO FCTC. Since then, new knowledge has been acquired and new initiatives have been undertaken to regulate waterpipe tobacco smoking. Add to this the impact of the COVID pandemic on the spread of the disease among smokers and its effect on their well-being. Unfortunately, waterpipe use remains a big challenge to control, particularly in EMRO, AFRO, and EURO. The previous Congresses were highly instrumental in issuing advisories and recommendations to regulate and control waterpipe tobacco smoking. For the purpose of this Congress, we attempted at building on the previous Congresses by offering an update on the subject and covering its diverse aspects. For day 1, we will listen to an update on the prevalence of use and its trends at regional and global levels, followed by learning about the scientific evidence of the health links between COVID and waterpipe tobacco smoking. Then we shift the discussions on what we know about the tobacco product itself and the importance of regulating flavorings, which are a major attraction for continued use, particularly by the youth and women. On day 2, we will be briefed on the status of testing of the contents of Waterpipe tobacco products and the efforts of the Tobacco Laboratory Network, TOBLabNet, in standardizing this testing, followed by evidence-based presentations that offer greater understanding of the demand on use and propose measures to reduce it. In addition, many countries have neglected the incorporation of Waterpipe tobacco products in their taxation schemes. We will be listening in day 2 and 3 from several experts on taxation, one of the best proven and most effective tools in tobacco control. We will conclude the program by learning from parties about their experiences in Waterpipe tobacco smoking and the regulation and some of the challenges that they continue to face today. This and the knowledge gained through the overall proceedings will hopefully set the stage for future work on Waterpipe tobacco smoke control. Before concluding my word, I would like to thank all the speakers from across the globe for their enthusiastic acceptance to be part of this international Congress. You were truly amazing in your interest in participating. I'm also thankful for the Knowledge Hub on taxation for being part of this program. I would like also to acknowledge the endorsement of FCTC Secretariat, WHO, and EMRO office to the workings of the Knowledge Hub over the years, including their full support to this Congress. Last but not least, a word of thanks and appreciation goes to my 2 partners, Dr. Rima Ash and Dr. Maya Romani, and the organizing team. Specifically, I would like to acknowledge the relentless efforts of Dalia and Jessica, who worked tirelessly to get things well organized and on time. And it gives me great pleasure to introduce the next speaker for the day. And we're very fortunate to have Dr. Adriana Blanco join us on this. She has a recorded message, but Adriana is the head of the Secretariat of the WHO Framework Convention on Tobacco Control since March 2020. And she's a physician with master's degree in policies to prevent addictions to children and adolescents from the Latin American Center of Human Economy. Those of us who know Adriana, she has been a strong advocate of tobacco control over the years in the many roles that she has played on the global scene. And with this, I'm turning it over to hear her pre-recorded message.
Dear friends and colleagues, thank you for the opportunity to be part of this important discussion. As you are all aware, Waterpipes has been gaining in popularity over the past 2 decades, notably among young people. Among the reasons for this trend are a variety of misconceptions about the safety of Waterpipe use related to other methods of tobacco smoking. There is a growing body of peer-reviewed evidence strongly indicating that Waterpipe smoke is just as harmful to health as cigarette smoke, if not more so. Waterpipe smoke contains just as many toxins as cigarettes, and because charcoal is typically used to achieve combustion, it also contains the carbon monoxide and carcinogens produced by burning that material. It is also worth noting that Waterpipe smokers typically inhale greater volumes of tobacco smoke than cigarette smokers due to the protracted nature of Waterpipe smoking sessions, thus exposing them to greater harm. It will perhaps come as no surprise, then, to learn that Waterpipe use and Waterpipe tobacco has long been a focus of parties to the WHO Framework Convention on Tobacco Control. We see this focus woven throughout the decision taken by parties at different sessions of the Conference of the Parties, or COP, the WHO FCTC governing body, which meets every 2 years to review the treaty's implementation. For example, a decision taken during the 6th session of the COP called on parties to strengthen the implementation of the WHO FCTC in relation to Waterpipe tobacco products through the integration of Waterpipe prevention and control into their broader tobacco control measures. Similarly, a decision taken during COP7 invited parties to strictly include water pipe use in the ban of tobacco use in public places as per Article 8 of the WHO FCTC, which requires the adoption of effective measures to protect people from exposure to tobacco smoke in indoor workplaces, indoor public places, on public transport, and where appropriate in other public places. The banning of water pipe use in public places not only reduces people's exposure to tobacco smoke, it also sends a clear message to the public regarding the harms that water pipes cause, countering false notions and messaging regarding their supposed safety and denormalizing their use. This kind of messaging is considered crucial to advancing the tobacco control agenda, as explicitly addressed in Article 12 of the Convention, which called for the use of all available communication tools to promote and strengthen public awareness of tobacco control issues. The Convention is clear on these issues then, and the parties to it can be in no doubt as to harms caused by water pipe use. The guidelines for the implementation of Article 8 indicate that each party should strive to provide universal protection within 5 years of the entry into force of the WHO FCTC for that party. How many parties to the WHO FCTC have seen this deadline come and go without action? Water pipe control was certainly possible during the COVID-19 pandemic, where we saw 17 countries during that period banning its use in public places for the first time. I call upon all countries to continue to strengthen their policies in this regard. These COVID-inspired bans on water pipe use in public places have likely contributed to saving lives during the pandemic, but they have to be kept in place if more lives are to be saved, not just of smokers, but of the many non-smokers who would otherwise be exposed to tobacco smoke. So I congratulate you, and I pledge our continued support to all the parties in the Eastern Mediterranean region and, of course, worldwide. We do not underestimate the size or the complexity of the challenge you face, and we stand firmly behind you in meeting them, with resources that include the Knowledge Hub for Waterpipe Tobacco Smoking, based at the American University of Beirut in Lebanon, as well as an upcoming publication being developed by the Convention Secretariat on how to include water pipes in tobacco control legislation. Thank you for your kind attention, and I wish you a productive conference.
Thank you, Adriana, for these guiding words and for your support. Our next speaker is Dr. Asmus Hamrick. He is a medical doctor with a research interest and master's degree in public health. He holds membership in the Royal College of General Practitioners in the UK and fellowship as a family physician specialist in Germany. He has been for years interested in the prevention and control of non-communicable diseases, NCDs, as well as promotion of mental health. He had held so many positions, but right now he is the director of NCD and mental health in the EMRO regional office in Cairo, in Egypt, and part of EMRO senior management team. Those of us who know him is always enthusiastic about taking part in these discussions on regulating tobacco, and he has been always very instrumental in giving some guidance and advice. Asmus, the floor is yours. Unmute yourself, Asmus.
Thank you so much. Dr. Ghazi, colleagues, ladies and gentlemen, it's a great pleasure to be here with you and to be part of the organizing team to organize this important online conference this week, jointly, of course, with our colleagues in Geneva from the FCTC and also the Tobacco Free Initiative unit in Switzerland. With water pipe smoking having traditional roots in our Eastern Mediterranean region, it has been a challenging endeavor to tackle this harmful practice regionally due to the many social and cultural complexities. However, our joint shisha control efforts now also expand far beyond our region, as water pipe use has gained popularity across the globe, and we all know examples, and Dr. Adriana also mentioned it. So the dynamics around water pipe use are complex. As said, sociocultural, but also economic factors, along with gender and age structures, strongly influence water pipe smoking behaviors and practices in our countries. For example, in our region, water pipe use amongst young people is of a particular concern. Smoking water pipe is seen as a healthier, cheaper, and more socially accepted form of tobacco use for many young people. And flavored tobacco water pipe use, along with poor enforcement of adolescent smoking bans, also significantly contribute to its widespread use, something that Adriana also mentioned. Indeed, current water pipe use amongst 13 to 15-year-olds in our region reaches up to 35% in some countries. We know that those who start using tobacco at an early age are more likely to experience several levels of nicotine addiction later, making this a particularly alarming statistic. Recent scientific evidence from the US suggests that indeed the effect of water pipe smoking on lung health are significant. It poses a real health risk to its users, and there are currently no scientifically based proofs that it helps with smoking cessation. These facts are the basis for an urgent call for action. The action starts with further research and knowledge exchange that should then inform urgent policy and regulatory approaches to effectively control water pipe use. This week's virtual conference serves exactly as an essential step of knowledge and information sharing by including both researchers and tobacco control advocates, contributing through their deep knowledge and long experience. Let me take this opportunity again to thank all speakers and participants for taking the time and attending and engaging in this event today. And I especially would like to thank again the FCTC Secretariat, the Knowledge Hub at AUB for organizing this event and for our continuous and valued partnership. Thank you so much.
Thanks, Asmus, for your kind words and for your support, the usual support. And we're always counting on your help in future endeavors for this Knowledge Hub, as well as other initiatives on regulating tobacco control, because as you mentioned, this continues to be a major challenge to all of us, those of us who work in this region. Next, I will invite our next speaker, another dear friend, Dr. Vinayak Prasad. Vinayak is the program manager who leads the WHO Tobacco-Free Initiative and responsible for the overall coordination of the tobacco control programs in WHO headquarters. And he liaisons with the WHO regions as well as with the convention secretariats. Vinayak has been very active in the field of tobacco control and non-communicable diseases. I've had the chance to work for him closely for so many years, and I found him quite helpful and with his guidance and help in trying to spearhead the initiatives on tobacco product regulations in my capacity as the chair of TOBRAG. Dr. Vinayak has been very instrumental in leading many initiatives at the global levels in India, as well as out of his office in Geneva. So I'm turning it over to Vinayak to say his word as we open the session on waterpipe tobacco smoking. Vinayak.
Thank you, Dr. Ghazi. Good afternoon, Dr. Asmus, Dr. Adriana, for this opportunity for me to say a few words. I'm glad we are having this Congress. The hard fact is that 8 million people in the world die prematurely from tobacco every year. All forms of tobacco is responsible, including water pipes. That number is a reminder that we need to do a lot more than what we are doing. the use of water pipe is no longer an emerald issue. When I was a child, I used to see in India, for example, these old people, typically retired, living in villages, using hookahs and water pipes. By the time my children have grown up, we saw water pipe bars, hookah bars come up. The law was trying to get that demolished, and some states in India achieved that. More recently in Uganda, I asked one of these boys in one of the hookah bars, what are you smoking? And he actually didn't know. He didn't know that it contains tobacco. He thought it's less harmful. It's still a reminder that even though we have a lot of knowledge about waterpipe tobacco, it has become a fashion, and it's something which has become a social norm amongst youth as it's going across regions. It's now available in more than 50 markets. That's a lot of countries, 50 countries. And we are not monitoring it so well. We do monitor, but I think it's a reminder that every time countries start doing national level surveys, they need to see in the global tobacco surveillance system that these questions are put not just in EMRO, but in all countries where there is some awareness that these products exist. So that would be my first point. My second point is that as you get into your Congress and discussion, I see a lot of very interesting sessions. What are the strategies you would want to use in terms of restricting youth access, in terms of building that knowledge? We see this word called knowledge transfer. It's quite popular, but knowledge transfer between the hub, between experts and member states and the governments. What about transfer of knowledge from governments to the public, to the citizens, to the common people? How do we leverage technology, which is a great enabler? How do we do that? I think those are the kind of questions I would really want to pose as we go into the Congress discussions. Because the industry is using water pipes and aggressively marketing it. It's placed conveniently in the malls, in different places where it attracts the young people. So again, that's an important point. And a reminder that a lot of the non-communicable diseases, we just heard from Dr. Asmus and also from Adriana, the linkages between water pipe and the NCDs, whether it's the cancers, a whole lot of cancers, and then the lung disorder, the COPD, which is one of the big killers in many countries. So those are, I think, very important issues to discuss in terms of how you build the knowledge transfer conundrum rather than stopping short of engaging the member states. My third point would be to see how the evidence base is continuously built. And Dr. Ghazi did reflect on it in his opening remarks. In 2015, WHO TFI issued an advisory from Tobreg. Based on Tobreg's guidance, we issued an advisory in 2015, and then also issued a fact sheet where we documented some of this evidence. We looked into waterpipe tobacco smoke and health issues. We made specific policy recommendations reflecting on specific articles of the Framework Convention on Tobacco Control. And now at this stage, we are beginning to develop a method to test the analytes, to look for toxicants. That would take some more time, but we are thinking and going forward on that because that's a request from the Conference of the Parties. So I'll summarize my closing remark that do look at what are the opportunities to increase monitoring of one, use, but of policy progress. How would we better look at compliance of the policies if it exists? The second is how do we work towards seamless knowledge transfer so that the last mile is fully aware that these are harmful products. And my third point would be to see how we use this in terms of using digital and tech solutions to bridge that gap. And I think those are important issues for consideration in the 4th Congress. So thank you very much for the opportunity, and I look forward to a very productive set of sessions. I'll try and join some of them. Thank you, Dr. Ghazi.
Vinayak, thank you very much for these remarks. And I would like to thank all our speakers at this introductory session. who will set the stage for the work to follow. I think all of us acknowledge some work has been done. Some decisions have been made by COP. Many advisories and recommendations have been forwarded by TOBREG and WHO. And there is a lot of work that has been done, but we have recognized that there is some more work to be done. And I'm sure after this session is over, still there are going to be more work for us for the future. So I would like to thank our speakers, and I'm looking forward to listen for the experts who are going to, update us on the state of knowledge for the coming 3 days. Before I turn it over to my colleague, Dr. Maash, I have just some housekeeping reminders. First, we would like to encourage people, they can always use the chat box or the Q&A to answer, to put on their questions. We'll be on the lookout for them in order to pass them on to the presenter. We will have an online evaluation form that will be sent next week to those who have pre-registered and attended the conference. Upon submitting the evaluation form, they would receive a certificate of attendance through their email. The meeting will be recorded, and we will decide on posting this on our Knowledge Hub upon the completion of these deliberations and proceedings. We will welcome any suggestions or comments from those who are joining us for the coming 3 days. And also, we're always welcome any suggestions for future work for the Knowledge Hub and our affiliate programs. So thanks again for the speakers, and I will turn it over now to my colleague, Dr. Rima Naash. Rima, currently she's a professor of global and community health at George Mason University. She was a colleague here at the American University of Beirut, and still is. And we are just sending her on a loan. I hope she will be back soon to be amongst our ranks. She was a tenured professor at the American University of Beirut. Her work has been in the preventive science, and she's an expert in several topics of public health interest, tobacco, alcohol, and mental health. And she has widely published in the field of tobacco. And I'm sure she will be sharing some of her new knowledge with us over the coming few days. She has been instrumental in making AUB a campus free of tobacco use. And for her effort, she's the recipient of the 2013 World No Tobacco Day Award. So Rima, it's a pleasure to be working with you, and I'm turning it over for you to moderate the next session.
Thank you. Good afternoon, Dr. Zakari, and good afternoon and good morning, everyone from around the globe. It's wonderful to be able to see colleagues and be able to share and move forward the science around waterpipe tobacco use. Of course, when we started, Dr. Zakari, planning for the first waterpipe tobacco conference, none of us would have imagined that one of the topics would be related to an infectious disease. And now we are here, and I'm going to be moderating a session, one that has topics around youth waterpipe tobacco use. And we all know how a waterpipe came as a method to hook youth to tobacco. So we are looking forward to hearing from colleagues about that, but more so about COVID and tobacco use. Many of us early in the epidemic remember industry-sponsored research around the protective effects of nicotine and all the hard work that advocates and public health professionals had to do around that to ensure that this misinformation is not spread. There are a lot of research areas that grew as a result of that. We're talking about the need to understand the behaviors and perceptions of smokers around COVID. We needed to understand how COVID spreads and to evaluate the effects of COVID, particularly around smokers. And we heard from speakers in the morning about how COVID even influenced and affected policies around waterpipe tobacco smoking and banning of waterpipe in many countries as a result. I look forward to moderating this session. I understand that there's a potential for participants to ask questions through the Q&A. I will be going through introducing our colleagues and speakers, allowing for the presentation and the question or two, either by chat or Q&A if possible. And then also you can also be asked to unmute and also ask your question directly. Our first speaker is Dr. Hiba Fuad from the WHO Regional Office. She's the focal point for surveillance, particularly NCD surveillance, and she's the head of that unit in the Eastern Mediterranean region. Dr. Fuad has experience of 15 years at WHO, working on strengthening the NCD agenda and focusing on monitoring and evaluation of national studies in the Eastern Mediterranean region. Dr. Fuad, the presentation is up and the microphone is yours.
Thank you very much, Dr. Arim, and it's my pleasure to join for the second time in this conference that has been organized for the fourth time. And if I can have the control of the slides, please, or you would like to move it from your side, organizer?
Dr. Fuad, you have control over your slides. If you can click the next slide, I think you can move.
Okay. Okay, so let us start by looking at where do we stand in terms of achieving the global targets on reduction of tobacco use. And before I start to talk about how countries at the global level performed toward reducing the tobacco use successfully, and we have seen it in many countries, I would like to highlight that WHO has been collecting information since 2008 on tobacco prevalence and different studies that has been implemented at the national and regional level to have the biggest database for tobacco use since 2008 in its published reports biannually, known as the GTCR or WHO report on tobacco epidemic. And based on that, the database is being used also to produce the trends towards achieving the target of reduction of tobacco consumption. And in front of us is the fourth trend report that looks at the reduction of tobacco use since 2000 and projected till 2025. Data has been included from 165 countries representing 97% of the global population. And as you see, in 2000, there has been like almost 1/3 of the global population, 15 years and above, were current use of tobacco. And in 2020, less than 1/4 or 1/4 were current use. And this rate is actually projected to decline further, around 1/5 of the global population of current use by 2025. Of course, this effort is, if it is maintained, there are some likelihood to achieve the target, not only in some of the countries as has been reported, but in more than this, if more ambitious is actually has been met. So how we do define the tobacco use and by WHO and how we report on it. In front of you, there is the big umbrella where any tobacco use is actually reflected in the smokeless and smoking tobacco. And in the tobacco smoking, the big chunk is actually focusing on cigarette smoking. So where is shisha and where is water pipe? There are some other types of tobacco that are considered as tobacco smoking, and this is including shisha, and shisha is reported here, but we definitely do not address the question explicitly. And this is a very important when we talk about how we will be able to monitor shisha and water pipe, not only for EMRO, but for all countries that actually has introduced shisha and which shisha has migrated to over the past decade. Of course, our definition, I'd like to highlight that does not include the e-shisha or e-cigarette or any electronic forms. And this is one of the biggest challenge of our data and our targets if we are concerned about how we tackle tobacco in all its forms. By deep dive and looking in the front of us on the current slide, where we look at the regional trends in current tobacco use among adults, as we see that all regions are tending to decline towards a target of reduction. But of course, not all regions will be able to achieve this target. Only the American region. And I believe this is the fastest decline that will be accomplished or achieved by America region. And the slowest one will be the WEPRO region. However, EMRO is actually among the slow achiever or slow reduction that will be actually expected by 2025. The trends actually of tobacco is impacted by many factors, and we will discuss this in the current slides, but let me highlight one important fact. Tobacco is one of the major contributors to NCD premature mortality. And by some efforts in analyzing the data of the regional contribution of the NCD risk factors, tobacco remained one of the major contributors to reduce the premature mortality. And if we achieve the 30% reduction, that would be important as a contributor. But if we agree on a more ambitious target, which has been discussed recently in the World Health Assembly, to look at whether the scenario that is actually ongoing as business as usual, or if countries would replace this with a more ambitious target of 50% reduction, tobacco will be among the highest ranked risk factor contributor to the premature mortality reduction. So looking at these trends for males and females, it's very obvious in front of us that males are the main problem, and females will achieve more than the target that is 30%. They may achieve in some regions 41% reduction based on 2020 baseline data. But for males, even for all the regions, including Afro, WEPRO, CIARO, males consumption is the major problem. The only region that may hit the target to achieve a reduction in tobacco use is the American region. This led me to actually show you that where do we stand in EMRO. In EMRO, we have a very complex and mixed bag of data that actually impacting our future in tackling the problem of tobacco or reducing the consumption. And as we see, the number of tobacco users by sex in front of us in the Eastern Mediterranean region has been increasing since the 2000 and expected to show more increase in the number of consumers by 2025. So we started by 61 million tobacco user in 2000, and now we are projecting this to more than 87 million tobacco user. And this actually is the problem that we don't see. We see that there is a good data, good decline. Countries are moving toward decline. However, this is not fully right, and especially when we look at individual country data. And here in front of us, the latest data coming from the Global Tobacco Control Report, or the GTCR, as we all know, and the age standardized prevalence estimate for current tobacco smoking among 15 years and above in Eastern Mediterranean region countries. And we see very alarming figures starting from Jordan, hitting more than 57%, almost 60% of males tobacco consumers are smoking. tobacco. And of course, these are very alarming figures, which mean that the current trend that we are all talking about might change very, very soon to a very opposite. And we need to tackle this, and we need to act toward this. And of course, this has been ranging till Oman that has now a 16% of the prevalence, but it is among of the countries that is expected to have an increase in tobacco use, and especially tobacco smoking. So cigarette is the main problem. Still, the cigarettes are the main problem that is reported. 70 to 80% of tobacco smoking is a cigarette. And this has been reported consistently in all the national representative surveys, whether it is Global Adult Tobacco Survey, whether it is a TQS that has been integrated in some of ongoing survey, health examination surveys, or even STEP survey. So coming to the shisha, we have actually included some of the questions, the standardized questions that actually the region tried to focus on and develop a model or a module actually to be integrated into ongoing surveys using the same pattern and same definition identified in the global tobacco surveillance system, especially the Global Adult Tobacco Survey. And the data came from these surveys that were successfully integrated questions on shisha. Like in Bahrain, we have seen that the percentage of water pipe or shisha users among the current adult smokers were reaching the highest of 28%, followed by Kuwait and Jordan, and occupied Palestinian or Palestine, Gaza and West Bank. We usually use these sites and combine them as for a national figure, followed by Egypt as a 20%. These data are actually standardized but it's not globally. And this is actually very specific to our region that has been using the shisha module that we, with our efforts, try to integrate in the national ongoing surveys. Striking for me, and striking when I was extracting the data and looking at the patterns and the use of females, by looking at the gender differences, there has been like for me as the first time to see that, for example, 67% of females in Palestine in a recent survey conducted in 2021 were using shisha as a percentage among current users or current smokers. And this is very, very alarming. We have never seen these figures, and we've been seeing this before as males overcome the rates of females. Again, in Afghanistan in 2018, STEP's data reaches that 38% of females among current adult smokers were using shisha, and especially at homes. And similarly in Jordan with 43%, Kuwait, and also Bahrain. These are all recent data coming with alarming figures on female high use and high consumption of shisha. I'd like to highlight here and comment on the statement made by Dr. Vinayak, where we need to have a cross-country comparison. He reported that 50 countries now globally are reporting using shisha. And we remember that we tried to do this in efforts for Global Adult Tobacco Survey, where we compared data between countries. And I think we are missing this. We need to have this global standard kind of indicators and questions and instruments by which we can compare the usages of shisha across countries. So this global figure is very old, I would say, that has been reported from the period of 2008 till 2013. And we don't have any alternative apart from studies that I will be showing at the end of my presentation. So coming now to the youth data. And for youth data, we have actually similar problem. Males or boys actually recorded the highest prevalence or percentage of use of tobacco among adolescents 13 to 15 years across the 6 WHO region and above the global level average as well. And by looking at the country data for current smoking, we have a similar high figures for boys compared to females, and we have a higher rates of females as well. And we all know that tobacco smoking is actually is increasing among youth, and it's a major problem. And we have a recent data coming from Palestine, Jordan, Kuwait, similar to adult figure exceeding a level of 30% and 40%. So what about shisha? And shisha, there has been a very specific module selected by all countries conducting GYTS in recent surveys, and data in front of us since 2014 till the last GYTS produced or published before COVID. And the data is actually reporting a higher rates compared to adults, with boys actually reaching 27% of shisha use in many countries, especially in Lebanon, Jordan, and this data is coming from UNRWA, followed by Bahrain, reached 26%, and Kuwait as well as 20%. So this is very important when we talk about how we will be able to produce data and compare it and produce trends. And I'm putting this slide, a previous slide, try to do trends, but we don't have enough data to actually draw this kind of information or to produce it to be useful. So shisha used, comparing this data with the current, used to be as coming a little bit down. However, we don't have enough points to draw the trends that we need to make sure that it is going down or not. So I try to look at the global evidence generated by many studies, and there has been some efforts in publishing some of the studies in a metadata analysis, looking at the systematic review as well, and looking at the data coming from different studies. And there has been many publications, but of course the standardization is lacking, and the information that we are getting, that is, there is no a kind of comparable estimate that we can use to report on shisha use. And of course, one of the important elements that we all agree on is that shisha use is one of the main problem among youth, and it is increasing not only in our region, but all regions that have received Arabic youth students, whether they are at university, at school, or in different part of the community. And of course, the origin or the nationality, considering Lebanese, considering coming from Syria, considering coming from all of Jordan, all countries that have highest rate are actually main nationality that has reported high usages in this country, especially in US and Eastern Europe. So this led me to my final slide and the conclusion with actually the statements that we need maybe to tackle in this session and to discuss with all of you on the limited availability of comparative data that can be used to report on shisha, and how we can push for adoption of a model that can be included and used, and how WHO can raise the issue to push country for generating more evidence on shisha use. And actually, since shisha is one of the major behavioral risk factors among males and females, and also among youth, this is very important to remark. We need to study not only the consumption, but we need to also look at the different policies related to shisha, starting by the exposure to secondhand smoke, the taxation, the warning, and all other Empower and FCTC strategies. There has been a very remarkable increase in shisha consumption in selected countries in the region, and this has to be studied very carefully. And of course, at the end, I would recommend that continued surveillance is very, very important to assess and inform policymakers to improve the policies and the control measures for shisha use, using all the methodologies that is available from the tobacco surveillance system. I will stop here and over to you, back to you, Dr. Rima, and thank you very much for attention.
Thank you, Dr. Fuad. We have, if you have a few minutes for questions or clarifications, I will try to keep my eye on the participant list to see if there are any raised hands. This will make it easier for me to identify questions. But before, until I can ask a question that was posed on the Q&A, and perhaps Dr. Fuad, you can address that. Dr. Muhammad Jawad posted on the Q&A with regards to the GATS. So he says the water pipe prevalence estimates from GATS are extremely low, no more than 5%, nearly all countries, and the highest in Vietnam. Have WHO ever conducted validation studies on the GATS survey for water pipe, as he has concerns over underreporting of water pipe use in our region?
Well, actually, the underreporting is one of the major issues, especially among females. Mm-hmm. And this has been remarkably seen in all studies with face-to-face interviews. And that's why if we look at the GYTS data, we can see higher estimates, but specifically and recently, and it was very surprisingly to me to see some of the reporting figures very high among females. But definitely still this kind of overall prevalence suffer from the underreporting. And I would like to say that also we have in our region, still cigarettes are the very most common types of smoked tobacco. Shisha may require a different kind of, let's say, media, social media gathering, or you know, it's a kind of different patterns and different types of usages, and we need to have more in-depth details and studies looking at the patterns. For example, in Qatar, they have 1 hour shisha session. In Egypt, it's a 50 minutes in a cafe. So there are different kind of shisha usages, styles and patterns. And of course, the marketing of shisha in the Western and in US communities is totally different. So also the environment impacting this. So I would agree with that. Yes, we have seen that. But there are a lot of remarks and a lot of discussions that need to be actually considered when we talk about the prevalence of shisha use. Over.
Thank you. Thank you. So I see there's a hand up. Catherine, would you like to unmute yourself if you want to ask this question? Is that possible to unmute Catherine, please?
Okay, yes. Can you hear me?
Yes, we can. Hi, Catherine.
Hi. So my question is, I saw a lot of graphs that were showing much lower female use than male. And then all of a sudden there was a graph showing in like 4 or 5 countries, higher use among females. Could you just repeat? I want to get the main message. Was that a different data source, or why was there all of a sudden that jump in that one graph?
Yeah, the graph that you have seen with a higher percentage of shisha use among current smokers, among females, that was adult survey, considering step survey with a module of shisha, considering TQS survey that is part of the GATS survey questionnaire. So these are a percentage of females using shisha among current smoking tobacco. Is that clear?
Yes, yes. And so that is much higher than just the overall prevalence of females versus males, right?
Right, because shisha is actually tackled as a prevalence only in some of the surveys, because we do not have a specific questionnaire on shisha. What do we do actually is addressing shisha as part of the tobacco smokers. And when we ask about the types of tobacco smoked, actually we calculate the percentage of user of such a kind of tobacco product among the current users. And cigarettes have the first rank, and then followed by others. And surprisingly, among females, in some of the recent studies, they reported shisha as a higher percentage, more than males among the current tobacco smoking. That clear?
Okay. Yes, and that's the adults. And then you had another graph about youth. And youth you're describing as 16 to 24, or what is the age group?
13 to 15, which is the source of the global youth tobacco surveys. And it is actually the tobacco surveillance system that address the all empower policies among youth in schools. It's a school-based surveillance system, and it looks at different types of tobacco use, and it has a standalone shisha module looking at the percentage of youth using shisha or water pipe.
Thank you, Catherine, for your question. If I may just, there's some follow-up questions that are related to mine that I'm going to just ask right now with regards to surveillance. So Dr. Fuad, you made a comment towards the end in conclusion, the need to continue surveillance. I understand at the country level that there's a lot of reliance on the GYTS and the GATS. Many of the data, however, if you look at the data that's used is as early as in 2013, 2014. So I would be interested to learn also what are WHO's plans to continue conducting those GYTS surveys more regularly. I don't know how country offices at the country level prioritize those surveys, but I know from working in the context of Lebanon that there is a need to do that continuous surveillance. It's been done only twice in Lebanon, I think, and we've always advocated for a next time because of exactly what you said from WHO's perspective, that we need to look at trends. How can you push more for that to reach that?
Well, there has been kind of efforts in different directions that we've been doing in collaboration with CDC, our partners, in implementing global tobacco surveillance system. And we have developed the what is called the TQS, Tobacco Questions for Surveys for Youth, which is actually extracted from the GYTS to be integrated into any ongoing youth survey. So for example, if Lebanon is interested in doing the multiple risk factor survey, the global school health survey, and looking at the policy at school and looking at the different risk factors, they can use this TQS and specifically add questions on shisha. And of course, it's based on the countries, and countries, they need to set their own priorities, and they need to identify what would make an impact towards the reduction and achieving the targets that they would like to achieve. And by ranking this, they can look at their priority and focus their surveillance system and surveillance mechanism to address the data gap. So I believe this is one of the solutions. And the other solution is that we are shifting towards what Dr. Vinayak has actually referred to, which is the digital era and the digital technology to address or to use the tablets at schools and generate more easily and more frequently data by remote data collection. I think we are on track, but a lot of challenges, especially during COVID. We have a gap now of data since 2019 till 2022 and maybe 23 with no data, not only on tobacco, but on other risk factors.
Thank you. Thank you, Dr. Fouad. So in closing, I want to ask a question that will address actually other questions posed in the Q&A related to more data. So there's a question related to where do electronic cigarettes, where are they located in this data? And in terms of tobacco use, do we have data around electronic cigarettes? There's a question about why we don't see comparison between developing versus developing countries. And then a more specific question related to Lebanon. So in terms of a slide that you showed between 2014 and 2021 on waterpipe tobacco use. Is there a place where you can guide our attendees and our participants on where they can find more information on those questions that they asked?
Yes, among the attendees, I believe that Dr. Alison Kumar from headquarters and a team with Dr. Vinayak, they've been tirelessly working on generating the global trends report. And of course, we are working here as a team in collaboration with other partners and other 6 WHO regions. The resources are available on our website. I will be putting these resources. The trend report has all the information required or requested by World Bank income groups, by WHO regions stratification, and the e-cigarette. It's actually coming on, and I think we don't have data right now to report on that. We only have few data from GYTS, and we started to push forward to include some of the questions on e-cigarettes and heated tobacco products in our ongoing surveys. However, we are facing a lot of challenges even to support the countries to implement these surveys. And of course, countries need to invest more in surveillance. And please let me know if any other questions that you might need. I can respond to this in the chat. I think we are running out of time and I don't want to take more.
Thank you, Dr. Fouad. And yes, and I encourage participants to follow up with you, particularly for specific questions on where they can access the resources. Our next speaker is Dr. Marie Hanna. She's going to be speaking about combustible and electronic water pipes in relation to advertising and marketing and their appeal to youth. Dr. Hanna has her PhD in cardiovascular physiology, and she is currently assistant professor in the School of Nursing, is interested in cardiovascular health effects and harms from new and conventional modes of tobacco use and the mechanisms of how those tobacco products work and affect cardiovascular function. She served on the American Heart Association Scientific Committee, which published a scientific statement on waterpipe use and cardiovascular disease risk. More recently in 2022, focusing on heart disease and using heart disease and stroke statistics. Her ultimate goal is to use physiologic data to drive evidence-based policy, specifically around novel and alternative tobacco products, a much needed area in tobacco use. Dr. Hanna, the mic is yours and your presentation is up, and please confirm that you have control over it.
Thank you, Dr. Nakash. Yes, I do. Do you see my screens?
Yes, we do. I do.
Perfect. Well, welcome everyone. I am delighted to be here today and thank you for the invitation. As mentioned, I will be talking about combustible and electronic advertisements and marketing, particularly appealing to youth and young adults. These are the objectives of my talk. First, I will provide an overview of traditional combustible water pipes and also evolution to electronic water pipes. We'll discuss leading reasons for waterpipe tobacco smoking, and we'll focus on advertisement and marketing used to particularly target youth and young adults. And then we'll conclude with future considerations. So this slide here shows a brief timeline of how recent the water pipe epidemic is. We know that in the late 1800s, water pipe was endemic to older Middle Eastern men where non-flavored tobacco was primarily used. In 1990s, and what ignited that recent epidemic was the introduction of prepackaged water pipe flavored tobacco. And from there, it quickly spread to Middle Eastern youth at one point with greater use among women than men. And Dr. Fawad talked about the recent increases among women as well. And now currently it is heavily marketed and advertised globally, particularly among young men and women as a safer alternative to cigarettes. These are the prevalence of current water pipe use, and current here meaning past 30 days. We know that up to 64% of college students in Egypt, Jordan, and Palestine, 22% of Czech middle school students, and up to 20% of US and UK college students report current water pipe smoking. Also in the US, current use has been recently shown to be higher among sexual minorities versus heterosexuals. So really the key point to the slide here is that water pipe smoking, as we know, and you all know, is a global epidemic. And the concern is that its use, particularly among the young and the youth, has outpaced research needed to understand their health effects and also inform policy. Now we know that the cigarette tobacco industry adjusts and also evolves their products over time. And the water pipe tobacco industry is no different, in the sense that in 2014, electronic water pipes or e-waterpipes, and particularly e-heads, were introduced as healthier or newer categories of vaping devices. And these products were primarily marketed as healthier, non-combustible alternative to traditional water pipe flavored smoking. Similar to other vaping devices, an electronic head produces this aerosol by heating a liquid, which typically contains nicotine, flavorings, and other additives, and that aerosol is inhaled by the user. This mini review here highlighted that virtually all studies of electronic nicotine delivery systems have focused on e-cigarettes, and little is known on e-water pipe use and also its associated potential toxicity and health effects. Now, this simple schematic here just shows the traditional as well as the electronic water pipe with its main components. Just a brief review. I won't go into much detail on this, but we have the head, the body, and the bowl. This is the combustible water pipe, where inside the bowl is the flavored tobacco and the charcoal goes on top. This is the electronic head, where flavored liquid typically goes inside here, and that whole apparatus goes on top of the water pipe. So in both of the combustible and electronic forms, the smoker inhales from the hose, the negative pressure heats up the charcoal, chars the tobacco, or with electronic water pipes, it heats the coil, it aerosolizes the flavored liquid, and then it gets inhaled by the smoker. Now, what's unique about water pipe smoking or vaping is that as compared to other nicotine delivery systems, the majority of youth and young adults here in the US smoke it in social settings. Now, if we step back and reflect on the history of the tobacco industry, they have adjusted their profits in a way and migrated to their various customers by developing and purchasing alternative tobacco products. And you can see in this timeline here, the black are combustible products introduced in the 1970s. The red is heated tobacco products. The blue is dissolvables. The green is smokeless and snus. And in purple are electronic nicotine devices. And that includes e-cigarettes, Blue, and Juul, which Altria, the parent company of Philip Morris, bought in 2019. Now, also in 2019, Philip Morris, which is the multinational tobacco company, they patented electronic water pipes. And this patent may very well not result in generation of popular electronic water pipe products, but this was the first time that a well-known transnational tobacco company promoted water pipe smoking products, which is likely because of the growing prevalence of water pipe among youth particularly. Now, a recent study that analyzed nationally representative US data from the Population Assessment of Tobacco and Health, which is a longitudinal study conducted by the National Institute of Health and the Food and Drug Administration, assessed self-reported reasons for water pipe smoking among US youth and adults. And the findings showed that the leading reasons include enjoyment of socialization while smoking, flavors, and believing that it is less harmful than cigarettes. These are the top three reasons. And they're similar among youth here on the left, age 12 to 17 years of age, and also adults on the right, both younger adults, so 18 to 24, and older. And you can see other reasons for water pipe smoking here. It includes that it's affordable. People use it. People who are important to the smokers smoke it, can smoke it in places where cigarette smoking is not allowed. People in the media smoke it. It helps people quit smoking. It's appealing advertisement. And finally, people cited that it's part of their cultural traditions. So this in a way can serve as a reasonable roadmap for policy and regulations. And it's also important to keep in mind that the majority, if not all these reasons, are directly or indirectly influenced by the tobacco marketing and advertisement. So in 2019, and in the US alone, the tobacco industry spent $8.2 billion on advertising and marketing their tobacco products, while all states combined spend less than $750 million on youth anti-tobacco and cessation programs, so a fraction of tobacco companies' marketing spending. So now I will spend just some time to discuss marketing strategies done by the Waterpipe tobacco industry to create a demand for their products. And they urge, with these ways, they urge new smokers, particularly youth and young adults, to experiment their products, and also encourage current smokers to continue using their products. And I want to particularly focus on flavors because studies show that adolescents and youth report flavors as a key reason why they started using a given product. And this figure here reflects nationally representative data showing that first flavored tobacco product used by youth aged 12 to 17. And you can see that 89% of youth reported Waterpipe to be the first flavored tobacco product used. Now, the science has shown us time and time again that tobacco products, flavored tobacco products, they are known to mask the harshness of nicotine. They increase the appeal of products. They may renormalize smoking, and they attract youth to use these products and make it easier to become addicted. And in the US, a key ongoing issue is that characterizing flavors other than tobacco have been banned in cigarettes, but not in Waterpipe products. And this is a critical loophole in current policies that the Waterpipe tobacco industry is using to hook adolescents and retain youth to use their products. Now, every year, millions of dollars are spent by the Waterpipe tobacco industry to heavily market their products, particularly appealing to youth and young adults, and emphasizing fruit flavors with bright pictures of fresh fruits, perhaps supporting the misperceptions and the illusion that these products are safer than cigarettes. These are some of the many advertisement marketing pictures the industry uses to attract young adults with comments such as healthy hookah without any adequate health warning messages. And you could see also the practice of replacing the bowl, the ceramic bowl, with actual fruits. And these could be appealing to a growing adolescent who may not otherwise smoke cigarettes. Now, the science is clear, showing that flavors, as I mentioned, it increases the palatability of tobacco products and facilitate and initiation and also continued use. And these are key study facts to keep in mind regarding flavored tobacco products. One is first use of flavored water pipe tobacco has been shown to be associated with subsequent use and current regular use. And two, in nationally representative path data, the odds of water pipe cessation were found to be lower for those who liked flavors compared to those who didn't. And last here, in a clinical laboratory study that investigated the impact of water pipe tobacco flavor manipulation on subjective experiences, found that young adults, hookah smokers, or water pipe smokers reported an enhanced smoking experience and also a greater interest in future use after smoking flavored versus unflavored tobacco. So the findings here and also in other studies suggest that policies and perhaps regulatory efforts to prohibit the sale of flavored tobacco can reduce access to these products and therefore decrease the increasing prevalence that we just noted from the previous presentation. Now, with regards to advertisement about the ease of accessibility to water pipe smoking, water pipes can be directly delivered to consumers' doorsteps by simply placing an order through phone applications or social media websites. And this article here highlights this global emerging issue with internet advertisement, and you can see the different countries, the US, Lebanon, Australia, the UK. So it's quite prevalent. And the problem is for youth who may not be old enough to smoke at a water pipe cafe or lounge, to avoid age restrictions, now this marketing strategy can provide an easy way for them to smoke at home and increases exposure to combustible product and secondhand smoke and thirdhand smoke also at home. Now, very briefly regarding the ease of accessibility, studies show that water pipe lounges cluster near colleges and university campuses, primarily, again, targeting the youth and young adult population. And the number of cafes have been increasing exponentially over time. Here I'm citing a 2014 study that identified closer to 1,700 water pipe lounges in the US, with 38% located within 3 miles away of at least one lounge. A more recent 2018 study showed that by comparison, 479 water pipe lounges were in California alone, with 57% of community colleges and 78% of universities located within 3 miles away. So these marketing tactics reflect another unregulated nature of water pipe lounges, specifically targeting youth. Tobacco companies, they figured out that social media platforms where youth and young adults spend a large majority of their time on are highly effective marketing strategies to capture the future generations of smokers. And this graph here shows the percentage of youth 18 to 24 years old using major social media platforms in selected countries in 2020, with YouTube, Instagram, WhatsApp as some of the top social media platforms. So the tobacco industry utilizes these platforms and also other unregulated digital ones to create a market and demand for their product. This study here provides a systematic overview of how leading tobacco product brands use popular social media platforms, including some Instagram, Facebook, Twitter, YouTube, and others. And you can see this table shows here with hookah as compared to other tobacco products and nicotine devices, they were most likely to have posts mentioning flavors. So this first row here, and you can see the percent and the number of posts from each platform. And also the second arrow shows that Waterpipe posts are more likely to feature young people in their posts and least likely to show health warnings displayed. These are some examples showing Waterpipe cafe and lounge marketing materials on social media. And you could see the affordability of Waterpipes, which has been cited as one of the top 5 reasons by youth for smoking. So $10 to $11 per session. And also claims supporting that Waterpipe smoking is benign and highlighting the social attractiveness of it. Now, concurrent Waterpipe smoking and alcohol use is a growing problem. And I thought to show this promotions here, as these are quite common and they've been depicted in social media advertisements for hookah lounges and restaurants. And these are some of the examples that may very well appeal, particularly to young women, promoting free Waterpipes with the purchase of alcoholic drinks, which is a concern, certainly with substance use. Now, because of the lack of regulations, many Waterpipe tobacco websites have unsubstantiated health claims related to Waterpipe use, such as this one related to electronic charcoal use, which is, according to this here, a must-have for the healthy smoker, healthier, smokeless, non-toxic, and safe. And in our lab, we have shown that the social media claims are simply not true and not supported by objective evidence. Here we conducted an acute exposure experiment where chronic Waterpipe smokers were invited to smoke a 30-minute Waterpipe smoking session heated by electronic charcoal, so similar to the product that was advertised earlier. And we also invited chronic cigarette smokers to smoke a single cigarette, and we measured blood vessel function or endothelial function by ultrasound of the brachial artery. And you can see here, these are the mean and individual percentage changes before and after the smoking sessions. And you can see that after smoking either product, whether it's Waterpipe or cigarettes, that endothelial function was reduced, suggesting impairment. And this is significant because the functional impairment is one of the earliest signs of the development of acute and also chronic cardiovascular disease. So the key point to this slide is that these social media claims, they're simply not true, and that electronic shisha charcoal is not safe. Now, these unproven claims fuels users' misperceptions, and they contribute to increased prevalence. According to a recent systematic review to review and examine the knowledge and attitudes and perceptions of Waterpipe tobacco smoking among college and university students, they found that the perception by many people is that it is less harmful, less addictive, and most socially acceptable to cigarette smoking. Now, again, in stark contrast with these perceptions, all current scientific evidence indicate that the constituents of Waterpipe smoke aerosol contain very similar chemicals to cigarette smoke, many of which are known to harm our health. And this figure illustrates here some constituents that result from Waterpipe tobacco combustion, which is similar to cigarettes, such as nicotine, nitrosamines, particulate matter, aldehydes, such as acrolein, and other toxins. Now, it's important to keep in mind that because of the burning charcoal, it's a unique source of toxicant emissions that's specific to Waterpipe as compared to all other tobacco products and nicotine devices. Some constituents differ into their qualities, particularly from cigarettes. So now there are additional exposure to charcoal combustion products such as carbon monoxide, particulate matter, and also other particles related to the combustible nature of charcoal. So Now I wish to conclude here by highlighting that, unlike cigarettes, as many of you know, regulation of water pipe tobacco products presents unique challenges. And that is because of the several complex factors that contribute to its increasing use among youth and young adults. And also one thing to keep in mind is that this is not a comprehensive list. It just simply highlights some factors that was discussed in the talk. The number one is the flavors. And we know that flavors are key aspects that defines the attractiveness and appeal of products to youth. Setting standards on those flavors, prohibiting their use is key. I also recall several years ago here in Los Angeles, as the city was moving towards banning the sale of flavored tobacco, there were strong oppositions from the water pipe tobacco industry, claiming that prohibiting flavors will take away their centuries-old cultural tradition and also their religious freedom. So these considerations are not simple and they're not easy to implement. One point is that with setting product standards, this not only goes to flavors, but also to regulate all components of water pipes. There's a charcoal, the hose, the bowl, because they all come in different sizes. And that makes it very hard to quantify someone's use, especially in clinical settings. We know for cigarettes, we can calculate pack years. We know the number of nicotine per cigarettes. But with hookah, it's difficult because there is the medium, there is the small, there is the large, the nicotine levels, they're not regulated, the flavors are not regulated, the sessions vary. So regulating components is a critical part of controlling this epidemic. The second consideration is to regulate social media and online advertisement and allow for effective health warnings on water pipe packaging and marketing. Also limiting the number of water pipe lounges and cafes close to university, college, and campuses. This will limit the uptake among young adults, increasing taxes. We know that that has been very effective in reducing cigarette smoking rates. And finally, prioritizing educational efforts and advertisement campaigns that focus on what is known, what are the signs telling us about the effects of water pipe smoking. And these will increase public awareness and also protect future generations from becoming addicted to water pipe smoking. And one last thing, will help make water pipe smoking not socially accepted as it currently is. And that's the end of my presentation. So thank you for your attention. Let me stop sharing.
Thank you. Thank you, Dr. Hanna. We have 5 minutes for questions that we can address to Dr. Hanna. I'm going to keep my eye on the participant list. The first question I see from my friend Rima Khalil. Can you please allow Rima to speak up? Rima, we have only 5 minutes for questions. Your mic, you're unmuted. You can go ahead. We cannot hear you. Are you? Okay, Rima, can you please type your question on the Q&A and I'll come back to you also. Thank you, Dr. Hanna, for the presentation. And we noted a lot of similarities between, water pipe, e-water pipes, and also vaping. You talked about proximity of vaping shops to colleges. So this is something that's very important in thinking about regulation and regulating vapes and products, and the importance of social media spreading and use. You had striking pictures. A picture says 1,000 words. You have a rich sort of bank of pictures that illustrate all the point that you are making. And I just want to add that in our thinking about, going back to your conclusions about various potential regulations and policies to limit, the spread of water pipe and e-water pipes, There's a lot of work that needs to be done on evaluating those policies specific to those novel and emerging tobacco products, because they have different features and might have different characteristics that we need to consider. And definitely the use of social media as a counter advertising. The industry has been really, as usual, ahead of us in using this platform to advertise for their products. We need, as public health professionals, to think of how we can access you through social media for counter advertising, programs and messages. I'm still looking at the Q&A and at the list. I do not see any hands up from the attendees with regards to any questions. If I can follow up in just 1 minute that's left before we move forward. Dr. Hannah, in recommendations, I'm very interested in how you, because you in your bio, it mentions the interests of translating evidence to policy and informing policy. At state level, how has it been easy, or maybe not easy? What have been the challenges in translating this evidence at the state level from where you are in the US and California?
What a great question. You know, it's not easy. We try our best. In a way, our goal is to inform the public first about the harms. The state, especially here in California, it's a bit difficult, but California, in a way, it's leading the nations in tobacco control. It has one of the lowest rates of smoking in the country, second lowest, second to Utah. So it's still not easy, especially with Waterpipe, because it's exempt from many other regulations and rules. So, for example, the flavors are banned from cigarettes, but they're not banned from Waterpipe. And these little loopholes are a way for the tobacco industry to hook young adults on these new products. So it's not difficult, but we've had people in our lab that become very interested in learning more about how it really affects their health, and they're surprised to find that it's actually opposite to what the advertisement tells them. So it's important to, one, get the word out there to the smokers, but also use it in a way that is effectively, it regulates the products to protect public health.
Thank you. Thank you for your response. I noted that, you know, the opposition can go so far in the arguments that they can come up with. So I can see religious freedom used as an argument. I just want to note here that for policy informing, that there's a role for community participation, and then I'm sure that that a lot of communities that listen and hear those arguments also can contribute in supporting advocates to move forward policy, as you know, this is an argument that's completely unacceptable. Thank you so much, Dr. Hannah. There's a question on the physiologic effects. If I can invite you to respond, please, on the Q&A to our colleague that has this question, and I will be moving forward now to our next speaker. Our next speaker is Dr. Silvano Gallas. Hello, Dr. Gallas. He will be speaking about the evidence on the association between tobacco product use and COVID through work that he's done on a systematic review. Briefly, I want to introduce Dr. Gallas, coming to us from Milan, Italy, and he has been an honorary associate professor also at the University of Nottingham in the UK, has extensive experience in research around in many fields of epidemiology and public health. He's interested in the epidemiology of tobacco use, particularly in Europe and in Italy. I look forward to hear about the findings from the systematic review on this topic. The mic is yours, Dr. Gallas, and I can see that your presentation is on. I can see your notes also. So if you want to,
I'm trying to modify this, but it is not possible anymore now. I don't know why during the demo section it worked, but okay. Now I do not have the possibility. Let me check.
Dr. Galas, this is Dalia again. Remember, we tried it from
Yes.
the one in the middle, impostazioni.
Yes, there is no more in impostazioni because we are in sharing a screen, and therefore it is not the same. I don't understand why. However, maybe it is better if
I will share your slides and give you access.
Perfect. Thank you. Thank you.
Perfect. Thank you. Thank you, Dalia.
Sorry, well, first of all, I would like to let me check if I find a way to.
No problem. We've all had our technological hiccups.
I do have a degree in computer science, but I don't.
No problem. As long as there's a solution, then that's not a problem. Thank you so much. Go ahead.
Okay, perfect. Thank you very much, and for the invitation. I would like to thank those who organized this interesting Congress. I will have the opportunity now to show you findings from the scientific literature and also from selected systematic reviews I conducted with my group here in Milan on the association between tobacco product use and COVID-19. Please, next slide. I will show you therefore, yes, next slide.
Doctor, you can control
I can use, okay, perfect, perfect. So I will show you information on the role of cigarette smoking on SARS-CoV-2 infection, and then on the role of cigarette smoking and second-hand smoke exposure on COVID-19 progression, hospitalization, severity, and mortality, and on novel products also, and the COVID-19, for COVID-19 infection, incidence, and progression of the disease. And also with a focus, with a specific focus on the role of Waterpipe on COVID-19 infection and severity and mortality. I will show you in particular three original systematic reviews we conducted on severity and mortality, on novel products, and on Waterpipes. Okay. Okay, so let's start with the cigarette smoking and SARS-CoV-2 infection. The most comprehensive systematic review on this issue is a living review by Simons and colleagues, updated to August 2021. And in this review, there is a huge number of case series. I counted more than 170 case series showing in general a relatively limited smoking prevalence among COVID-19 patients and among SARS-CoV-2 positive subjects. These findings from case series were emphasized by some researchers, and then it has been shown how these researchers were also linked to the tobacco industry. Actually, it is important to put in evidence that these case series have several limitations. The study design has several limitations. In particular, they do not have a comparison group, and therefore they cannot be used to support any causal conclusion. Moreover, most of these studies suffered from selection biases and information bias. Therefore, we need to rely on cohort studies. The systematic review by Simons and colleague showed almost 40 studies dealing with the association between cigarette smoking and SARS-CoV-2 infection. In particular, they found that a relative risk of 0.67 statistically significant for current versus never smokers, and a relative risk of 0.99 for ex versus never smokers. In order to well interpret relative risks, we can say that if the relative risk and the 95 confidence interval is below unity, then we can talk about an inverse association and a protective effect. Whereas if the relative risk and in particular in the 95% confidence interval includes unity, there is no association. Whereas if the relative risk and the confidence interval is above unity, we can talk about a direct relationship and the excess risk. In this case, we find for current versus never smokers a decreased risk. The apparent decreased reduced risk for current smokers can, however, be partially or totally explained in terms of different characteristics of current smokers as compared to never smokers or non-smokers. I give you just a couple of examples. Current smokers, we know that have lower social interactions as compared to non-smokers, and consequently, they have less frequent occasion to be infected by SARS-CoV-2. More importantly, current smokers, we know that they experience cough and other COVID-19-like symptoms, and consequently, current smokers are more frequently tested as compared to non-smokers. And the core studies based on symptomatic populations, which are the large majority of all available cohorts, have an excess of current smokers. As a consequence, there is a sampling bias which results in these studies in an artificial reduced risk of SARS-CoV-2 infection for current smokers. And therefore, at the end, we can explain this partially or totally the inverse association between current smoking and COVID-19 incidence. With reference to smoking and COVID-19 progression, and therefore hospitalization, severity, and mortality, we conducted a huge systematic review, a comprehensive systematic review on the association between cigarette smoking and the risk of COVID-19 hospitalization, using all the cohorts we found of SARS-CoV-2 positive subjects, and on the risk of COVID on the association between cigarette smoking and the risk of severity and mortality, using all the cohorts of COVID-19 patients. We used an original and innovative methodology to identify all the studies dealing with this aspect. This methodology involved an umbrella review and therefore a systematic review of reviews and meta-analysis, and a traditional review. These reviews were updated to February 2022. As we can see from this flow chart, we observed more than 60 systematic reviews available, and we integrated in our search strategy also all those systematic reviews. At the end, we identified 48 papers on 48 papers on hospitalization, 190 papers on severity, and 184 papers studies on mortality. Okay, this is here we can see the association between smoking and COVID-19 hospitalization. As we can see, we had approximately 40 studies. I cannot see the last, the bottom part of this. Let me check if I can find a way to. Okay. Sorry. Okay, so so the pooled odds ratio was 1.06 based on 36 studies for current versus never or non-smokers, and the odds ratio was 1.16, statistically significant for former versus never smokers. Okay. With reference to smoking and COVID-19 severity, we observed a pooled odds ratio of 1.34, statistically significant based on 124 studies for current versus never or non-smokers, and we observed an odds ratio of 1.41 based on 44 studies for former versus never smokers. With the reference to mortality, we found approximately the same estimates. Therefore, the pooled odds ratio based on 119 studies was of 1.32 for current versus never or non-smokers, statistically significant, and it was 101.46 based on 44 studies for former versus never smokers. In here, we can see the summary table for smoking and COVID-19, and this table shows that there is evidence of a 30 to 50% increased risk of COVID-19 progression and therefore COVID-19 severity or mortality for both current and former smokers compared to never smokers. With reference to, it's possible to go ahead now. And
Doctor, can you run your slides in slideshow? Are you able to run it?
Well, how could I? Because I don't see below. This is a problem because I don't see. I can't access the last part. Okay.
Okay.
Yeah.
Is this better?
No, because I can't see the last part of the slide, and therefore and this is the main problem. However, okay. I try to remember what it is written.
If you'd like, you can, if you want, try to remove the slideshow again, if it's better for you to see.
Yes, it is better. It is better. Okay, perfect. Okay, so there is evidence of 30 to 50% increased risk. Now I cannot go to the next slide. Okay. With reference to secondhand smoke exposure and COVID-19, in 2021, it was published this letter to the editor in tobacco control entitled Secondhand Smoke Surveillance and COVID-19 a Missed Opportunity. In fact, they showed that there was a lack of knowledge on the effect of secondary smoke exposure on COVID-19 progression. Actually, in the scientific literature, we observe that the knowledge on the issue is limited to only one study showing more frequent symptoms among children exposed to secondhand smoke. We have finalized the study in Italy, the COSMO-IT study based on 2,000 COVID-19 patients, and in this study that is now under review in a journal, we observed no association between secondhand smoke exposure and COVID-19 severity, but a statistically significant 70% increased risk of COVID-19 mortality for those COVID-19 patients that are daily exposed to secondhand smoke compared to those not exposed to secondhand smoke. With reference to the role of electronic cigarettes and heated tobacco products on COVID-19, we conducted a systematic review. I will show you preliminary findings from this systematic review and association between novel products, electronic cigarettes, and the heated tobacco products, and the risk of COVID-19 incidence, hospitalization, severity, and mortality using the same methodology involving an umbrella review and a traditional review. This review is updated to June 2022, and it showed 13 articles on incidence, 1 article on mortality, 5 actually, not 4 articles on severity, and 1 article on hospitalization. As we can see from this slide and the next one, we provide here all the studies on the relationship between electronic cigarettes and the SARS-CoV-2 infection. As we can see, practically all the estimates found were mainly odds ratios were above unity, and therefore they suggest, let's say, that there might be a higher risk of infection for electronic cigarette users, and some of them were also statistically significant, those in bold, as we can see. So out of 9 studies, none of them reported a protective effect of electronic cigarettes on smoking on SARS-CoV-2 infection. We can summarize these findings saying that e-cigarette use might increase the risk of SARS-CoV-2 infection. At least 3 studies, moreover, showed that electronic cigarette users had more frequent COVID-19 symptoms or severity and mortality, and a large cohort from the UK did not find any relationship among ever smokers, any relationship between electronic cigarette use and COVID-19 progression. With reference to heated tobacco products, we do not have sufficient data. We have just a couple of cross-sectional studies finding no significant association. With reference to Waterpipe and COVID-19, following the invitation to come to this Congress, we decided to conduct a systematic review on the association between water pipe use and the risk of COVID-19 incidence and progression, also because there were just a few available studies in the literature. We considered a traditional review because we didn't find any review, systematic review of the literature on this issue, and this review is updated to September 2022. We started from 62 eligible papers, studies, and we obtained only 2 studies on incidence, 5 studies on severity, and 2 studies on mortality. With reference to incidence, we found 2 studies dealing with this relationship. Callan, I know that will be the next speaker, and therefore I will not focus the attention on this result. However, of the paper by Callan and colleagues was the only one considering water pipe use, whereas Mostafa and colleagues considered the water pipe together with other tobacco products. So it was not focused on water pipe. What Callan found is a odds ratio of 2.92 for an adjusted odds ratio for water pipe users as compared to never water pipe users or cigarette smokers. With reference to water pipe, the relationship between water pipe and COVID-19 progression, we found 5 studies dealing with this issue. 3 of them found no significant difference in terms of severity or in terms of symptoms. There is this study by Cambats and colleagues, is a small study, which found that the proportion of patients with severe COVID-19 was higher among non-smokers rather than on dual users of water pipe and cigarette. But it is extremely important to notice that in this study, dual users had mainly less than 50 years of age, whereas non-smokers had more than 50 years of age, and therefore this result, let's say, is affected by the age of various subpopulations. With reference to severity, in particular mortality, 2 studies provided information on the relationship between water pipe use and COVID-19 progression. Still, Callan will probably show us later in detail this study. However, in this study, the severity of symptoms were higher in water pipe users as compared to never water pipe or cigarette users, and also mortality was higher among the water pipe users as compared to never smokers. And also this study by Gamari and colleagues in 2022 showed a statistically significant odds ratio for water pipe ever versus never users with reference to the need of ventilation therapy. In conclusions, we can say that the apparent decreased risk of COVID-19 incidence for current versus never smokers could be explained in terms of different characteristics of current smokers as compared to non-smokers, and in particular to never smokers. We observed a robust evidence of a 30 to 50% excess risk of progression of disease for smokers, both current and former smokers, as compared to never smokers. And I didn't show you before, but pulling the estimates from the 3 available cohorts that are based on the general population, the cohorts that have a follow-up until the death of their subjects, and therefore they consider both incidence and mortality. We observe in these studies a statistically significant 45% excess risk of COVID-19 mortality in never compared to never smokers. We can say that part of the 6.5 million deaths due to COVID-19 are attributable to smoking. The study is available on the role of electronic cigarette use on COVID-19, did not find any significant association or found an increased risk of COVID-19 incidence. So none of the studies found a decreased risk of COVID-19 incidence. And with reference to water pipes, we must say that the original studies on the association between water pipe use and COVID-19 are limited and with limited quality, most of them. And the only study on incidence focusing on water pipe users provided a non-significant higher odds ratio for water pipe users as compared to non-users. And overall, the few available studies on the progression of COVID-19 suggest no relationship or, if any, a direct relationship between water pipe use and COVID-19 severity. Regarding mortality, we have only 2 studies dealing with the issue, and we showing more frequent deaths among water pipe users, although the results were not significant. Thank you for the attention, and sorry for these problems.
Thank you, Dr. Gallus. Thank you, Dr. Gallus, and thank you for this presentation. We know how much effort goes into those systematic reviews. There's a lot of valuable information, and we're looking forward to seeing publications of those findings, particularly to the one related to Waterpipe and COVID-19. I understand probably this is a live systematic review, as there are currently a lot of studies that probably can be added to this and that are coming up in the literature. Unfortunately, there's no time in keeping time. There's no time for questions orally. However, I can see from my Q&A that all the speakers have been excellent in responding to questions through the Q&A. So I really want to invite everyone to pose their questions on Q&A, and Dr. Gallus will kindly respond to those. Don't miss the opportunity to ask questions just because we are out of time. Please go ahead and do that. And great to have you in this conference, Dr. Gallus.
Thank you. Thank you.
Thank you. So we are going to be moving forward to our next speaker. Our next speaker will be talking about waterpipe tobacco smoking and COVID-19. And I want to introduce my colleague, Dr. Ibrahim Kalan, who is currently an assistant professor of epidemiology at Eastern Virginia Medical School in Norfolk, Virginia. We are neighbors. He's an epidemiologist committed to reducing health disparities driven by commercial tobacco use. And his studies range from analysis of epidemiologic surveys to clinical studies and community outreach and research. The program of his research centers around understanding health disparities in tobacco product use, evaluating evaluating policies and health communication strategies and understanding how those policies affect youth and consumption among priority populations. Dr. Kalan, the mic is yours, and I can see that we are in the process of loading the slides.
Thank you, Dr. Nakash. And I am not sure if you are seeing my slide or not.
We can see, but not the full view. We can see the one.
Yes.
Perfect.
Okay,
Now,
great. Thank you again, and thank you for organizers of the 4th International Conference on Waterpipe Tobacco Smoking for the invitation. And today I'll talk about waterpipe tobacco smoking and the COVID-19 pandemic. So you introduced me, so no need to introduce myself. I jump to the slides. Before continuing, I have no conflict of interest to disclose. As a tobacco researcher, that I believe all of us are here, we have one maybe common mission, that is to protect people who do not use tobacco products and encourage users to quit, and provide scientific evidence to inform regulation of these products. So these are like our main mission as a tobacco researcher, but sometimes we are facing with unexpected situations that may affect to achieving these goals. One of them was and is COVID-19 pandemic, which affects like the many, not only the about the life of million peoples, also it affects the research and regulation and anything related to tobacco control, mainly in low and middle income countries. So before going forward for about COVID-19, the main problem is the tobacco use that poses an enormous threat to public health worldwide. And this mode of consumption is killing almost like more than 8 million people annually. And again, it happens mostly in developing countries. The main contributor is cigarette smoking, but we have other contributors that is almost, I would say, is hidden because it's extremely rooted in culture. The waterpipe tobacco smoking, and our colleague also talked about that in previous talks. Waterpipe tobacco smoking is harmful. We all know that. And there is like the well-established research that shows that waterpipe is dependence-inducing among adolescents and is associated with several dire health consequences. So adding to that problem, like the existing problem, the other problem that came out 2 years ago was COVID-19 that is still wreaking havoc on families' welfare and economy. The COVID-19 is so far infected more than 600 million people, and with unfortunately killing the 6.5 million globally, although we had the 12 billion vaccines so far until September 23rd. That's the last updated from WHO. But still we have a lot of challenges and struggles against COVID-19. And most importantly, the raising the restriction in many countries that are also reporting the high level of COVID-19. And it's the unexpected that if it will decrease in the upcoming fall or winter, or it will increase, and hopefully it will decrease, but we should be aware of the transmission with tobacco products use, mainly waterpipe tobacco smoking. So Eastern Mediterranean had also 23 million cases, and with the highest epicenter of COVID-19 was in Iran. And therefore, our attention needs to be devoted to water pipe as a potential vector for the spread of COVID-19 and other infectious diseases such as tuberculosis. So for Dr. Gallus explained about the systematic review, and we are seeing that compared to cigarette, there is little data available how people think about smoking and also their progression about like the water pipe smoking and the COVID-19. Before continuing my talk, I would like to raise this point that unfortunately there is no more funding for research in low and middle income countries to get the better understanding of association between water pipe smoking and COVID-19. I'll talk this in the further slides, but here we published water pipe tobacco smoking as a potential conduit of COVID-19 in tobacco control blog in early days of COVID-19, and we raised the point that water pipe smoking is one of the main aspects that should be regulated to avoid more infections in low and middle income countries, mainly in like those countries. And other like the colleagues in Canada also, they called for action about hookah smoking and COVID-19. And this shows the importance of focusing on water pipe smoking, because cigarette smoking technically they don't share their cigarettes. They were sharing in the past, but these days they don't share their cigarette. But we are seeing that water pipe smokers, they share the hose between each other, or just cleaning is not that much enough to wash out like the COVID-19 virus. One main issue is the water pipe smoking being extremely rooted in culture. And users most of the time do not recognize the risks like COVID-19. And as Dr. Gallus explained, secondhand smoking also is very crucial in this case. So here is a video that was circulated in the literature, like in social media, excuse me. And it shows that in Iran, in a religious like the event, people were wearing the mask here. They wear masks, some of them. And here you can see these four, mostly like the elderlies, they are smoking hookah in I would say, not open area. So here you see the water pipe smoking in their religious, like the events, and they are sitting next to each other. Here we have water pipe smokers facing many toxicants during the COVID-19 and secondhand smokers. One of the unfortunate thing is that the Iranian, like the actor, this person also was smoking water pipe. Anyway, this shows that how deep is the water pipe smoking problem in low and middle income countries, especially in Middle East, that is extremely rooted in the culture of these people. And I remember in Lebanon also people were smoking water pipe when they were protesting and street. And this is like one of their cultural things. And we need to raise awareness about this, how we need to conduct the studies to better understand water pipe smoking and COVID-19 association. So in the early days, we conducted few studies, such as COVID-19 and beliefs about tobacco use, which was an online cross-sectional study. I will touch on that and some results from that study. And also, we described the characteristics of hospitalized adult smokers and never smokers with COVID-19 in Iran. So our aim was to determine the beliefs and perceptions surrounding the use of tobacco products and COVID-19 infection among Iranian adults. And as Dr. Hanna highlighted our articles that about hookah, home delivery, which is also a crucial issue. If we are closing the hookah bars, but still we have availability within houses with those like the new version of marketing. Hookah home delivery provides the hookah at home, and the kids who are not allowed to smoke cigarette, but they are smoking water pipe, and that is because of the culture. Parents don't I wouldn't say care about that, but they don't have any restriction for that because they think no harms from water pipe. And to see the relationship between water pipe and especially like the tobacco use and COVID-19, we conducted this study. We in early COVID-19 times in May 2020, we conducted an online survey of among 944. We had like the 1,200 participants, but 944 data were usable. And at the time, Iran was an epicenter of COVID-19 in the Middle East. Our participants were the average age of 35 years, and they were included never smokers, either water pipe or cigarette, smokers of water pipe and or cigarette. And we had like the 2 participants who were using e-cigarettes, so we excluded them, and because of the low sample size. To collect the data, at the time, so the only thing to collect data was online to get these kind of study done. And that was the early COVID-19. It was not like the many online platforms, especially in Iran or like the surrounding countries to use, but the Telegram is the application that at least 50 million Iranian use this Telegram. So we distributed the study link with the informed consent in the groups, more than 500 followers. And we get 944 completed like the questionnaire from participants. We collected data on demographics such as age, sex, and etc. And also we asked, with our colleagues, like the tobacco researchers, we developed questions because there was no COVID before that and no similar study were conducted before about the COVID-19 and smoking. So we just developed the questions and we translated and back translated from Farsi to English and English to Farsi. And then one of these questions is here that we asked, in your opinion, what will be the outcome of hookah smoker who is infected by water pipe? So this study was approved by Erbil University of Medical Science and Health Services, IRB. At the time, the study had 0 funding, and we even were, for those, some of the Telegram groups, our colleague, we were just distributing the link in the snowball sampling, and this may not be a representative sample for the Iranian population, but it was very crucial and very important at the time, and still now is. And I will show you some results from that study that we found. Compared with never smokers, we found that the cigarette smokers in our multinomial regression analysis, we found that the cigarette smokers were less likely to believe that smoking cigarette can lead to spreading COVID-19. In the parentheses, I would say currently we are using the National Health Interviews Survey data from the US, and the preliminary data shows that the cigarette smokers, they self-report less likely to have the COVID-19, but at the same time, they report less likely to have the COVID-19 tests compared to non-smokers or never smokers. So it's like a very complicated area of research, and it's like especially in the early COVID-19, it was just commercialized that smokers don't get COVID-19, and that may affect the belief of people. So we conducted this study to see how it could be affected. And it was actually quite interesting results. So compared with never smokers, we found that waterpipe smokers were more likely to believe that smoking waterpipe at home is a safe practice, protect against COVID-19, and may lead to a more rapid recovery from COVID-19. This is very crucial among waterpipe smokers and second-hand smokers, especially when there is a well-established literature that evidence shows that the smoking, either waterpipe or cigarette, can massively affect the respiratory system and reduce the function of the lungs and damage the lungs. So we had like the other questions asking among of those people who quit smoking in the past 3 months, because our timing was in March 2020, and in the past 3 months, COVID started late December 2019. So it was a good timing to ask in the past 3 months, and 172 smokers quit smoking, and they mentioned that they quit due to 40%, over 40%, they quit due to COVID, and they will continue even after pandemic to be smoke-free. And others, also 40%, they mentioned they quit due to other reasons other than like the COVID-19, but very like the 10%, a small percentage, mentioned that they quit due to COVID and will resume after this pandemic. This shows that like the heterogeneity among smokers, either waterpipe or cigarette, that they are uncertain about quitting smoking because of the availability, cultural, and many other reasons that are hidden or latent, particularly for waterpipe tobacco smoking, that has, as I mentioned, is culturally rooted, extremely rooted in our culture, and that needs to pay more attention for this part. So one, like the very small part of our study that also Dr. Gallus highlighted this, we had the same time, we also were conducting a study in a hospital that was really hard to conduct. I should thank my colleagues at RW University of Medical Science, because at the time, people like the nurses or the administrating office or even researcher were scared of attending like the research area to collect data directly from patients. Or if you are aware that even in many countries, neighboring countries of Iran, there is no like consistency to collect data, at least for waterpipe smoking, like the asking question, do you smoke? and what do you smoke, how do you smoke? There is no such a questions. They may ask like do you use tobacco or do you smoke cigarette? So Waterpipe is not like collected that at the time. So we had researcher-based developed questionnaires. So we asked those questions. As you can see here, we had a sample of 193 hospitalized patients, and it shows that the Waterpipe smokers were more likely to pass away compared to cigarette smokers. But again, the sample size were very low, and we did not, this is just a descriptive study, and it has like the limitations, and with the more funding or not like unfortunately due to some political reasons like the economic sanctions stuff, we cannot get the funding from NIH to conduct these kind of studies in Iran. So that's an unfortunate thing, but at least we have colleagues in Iran that we are communicating to conduct these kind of studies. And it shows that the Waterpipe is also affecting the COVID-19 is affect Waterpipe smokers, and there is need to highlight this in the regulatory actions, specifically in that area for Waterpipe smoking. So in summary, we found that the misperception about smoking and COVID-19 were observed in an epicenter of COVID-19 in the Middle East at the time. And we suggest to raise the awareness, promote smoking cessation, discourage sharing of Waterpipe and smoking at cafe or home during the pandemic. And although there was a lot of attempts for that, as you saw in the previous slides, I show a video that in a religious event, they were smoking Waterpipe, and there were a lot of people, even with wearing masks. So we know that wearing masks for the smoke may not also affect, were affected for COVID-19, but not for secondhand smoke. And that's like showing the serious problem in that region and needs like the critical action from researcher sides and regulatory bodies. Such efforts are likely to help stop the spread of COVID-19, excuse me, and protect smokers and non-smokers alike from exposure and dire health consequences. Abdul Aziz Al-Aghali in 2019, they published a paper about MERS and Waterpipe smoking in Saudi Journal of Biological Science. So I just have their citation here, like and also the conclusion part of their study, that they suggest the replacement of reusable hoses with one-time use hoses in addition to a close inspection of Waterpipe components to assure the appropriate cleaning and sanitization of Waterpipe device. So Waterpipe smoking is something that you may go and you see many people smoke their own Waterpipe in the cafe, but for the friends, families, gathering at home, usually there is only one Waterpipe, and they share that Waterpipe even with kids. And that's not only raised the question, like the concern for COVID-19, like the spread, also for other infectious diseases. And in addition to that, the dependence characteristics, the PhD dissertation was about the nicotine dependence among adolescent Waterpipe and how it differs from cigarette smokers, adolescent Waterpipe and cigarette smokers. So we found that the adolescents get more addicted to Waterpipe and more sooner, almost double time compared to cigarette smokers. So the addictiveness of water pipe also huge, especially for youngsters, that they may get addicted to water pipe, and that we have studies showing that water pipe smoking among youth can lead to cigarette smoking when they get older in their adulthood, and they get like the lifelong sustained cigarette smokers that can reduce their life expectancy almost 10 years. So here I come back to our mission as a tobacco researchers, which is protecting people who do not use tobacco products, encouraging users to quit, and provide scientific evidence to inform regulation of these products. So we should be prepared not only for COVID-19, for also other unexpected pandemic or outbreaks that is in part related to the respiratory systems and tobacco use. And I would hope to see not only No Tobacco Day, but also the No Tobacco 365 days very soon in the future. Thank you for listening, and here is my contact information. I would be happy to answer any questions. And
thank you, Dr. Kalan.
Yeah,
we are open
for
questions. We are open for questions on the Q&A to avoid delaying everyone and the program. Thank you, Dr. Kalan, for the insight on the studies that you led and conducted in Iran, despite the methodology difficulties and resources that are available. It's very important to go do that extra effort in conducting those studies in those contexts also. This is very valuable information on water pipe and COVID use, and I encourage you to continue that collaboration at the local level so that we can enrich our understanding of those relationships. I want to move forward now. I also want to invite again on Q&A questions for Dr. Kalan. If you have any, he will be available to respond to them till the end of the time today. But for the interest of time and not leaving many of you in the time zones that are very late now in the evening, we want to move forward to our next presentation from Dr. Talhout. Dr. Talhout is our senior scientific advisor that's involved in tobacco product regulatory science, focusing on Article 9 and 10 around regulation and control. She's the head of the WHO Collaborating Center for Tobacco Product Regulation and a member of the TOB Lab network, which develops methods for analyzing tobacco and related products and conducts research to advance tobacco product regulation. She has taken many advisory roles to governments, to the EU, to the WHO around tobacco product testing, and will be presenting specifically to us today on flavorings in water pipe tobacco and lessons learned from what we know so far about the science of water pipe flavoring. Dr. Talhout, the mic is yours.
Yes, thank you very much for the kind introduction. And I'm honored to be invited to this conference on so many different aspects of water pipe tobacco product use. And indeed, I will focus on flavors and flavorings in water pipe tobacco products, and also lessons learned from the experience of the European Union in regulating tobacco flavors. Dr. Reish Khanna already mentioned that flavors in tobacco and related products, especially water pipe tobacco, are a very important factor that leads to increased tobacco initiation and consumption. So flavors increase attractiveness, make tobacco use smoother, reduce harm perception, are especially attractive to used non-smokers, and increase tobacco product initiation and consumption in general. So this is the reason why some jurisdictions regulate flavors in some tobacco products. For example, in the European Union, characterizing flavors are forbidden in cigarettes and roll your own, as in the United States. And also some member states regulate flavors in e-liquids. So maybe this would also be a good idea for water pipe products. Let's see about that. Regarding flavors in Waterpipe products, you can see a few examples here on the slide. Waterpipe products with or without tobacco contain predominantly fruity or sweet flavors. And as said, such flavors are especially appealing to youth and lead to a false perception of using a safer product. And the attractiveness of flavors is an important reason to start and continue waterpipe smoking. So regulation could be necessary to reduce prevalence. Apart from waterpipe tobacco, there's also related products that do not contain tobacco, but can be used in waterpipe. For example, steam stones that you see depicted on the picture on the right-hand side. Those are small porous mineral rocks soaked in a liquid containing flavorings. They're available with and without added nicotine, and they are often marketed as less harmful than waterpipe tobacco. Another example is herbal molasses, which is a flavored plant-based product without tobacco, which is also marketed as less harmful than waterpipe tobacco. So at the RIVM, we carried out a study on flavors and flavorings in waterpipe products, also to see if there's a relation between them. Our study was based on database and chemical analysis, and it was led by my colleague Ingrid Bakker-Hart. We wanted to provide an overview of commonly used flavors and flavorings in tobacco and related waterpipe products. And with the latter, I mean herbal molasses and steam stones. And we also wanted to see whether they have similar flavors and flavorings in all three product classes. So let me start with the database part. In the European Union, manufacturers via the Tobacco Products Directive are obliged to send data on their products to the national regulators, so in our case, the Dutch government. We also have access to those data, and in 2019, we found that 249 waterpipe tobacco products were registered. And we assigned flavor categories, so which is a general category of a flavor, such as fruit. We assigned them to all those products, and they could be assigned in 237 of the cases based on their brand names and product descriptions. Now, based on that, we drafted the flavor wheel of waterpipe tobacco products. Previously, we drafted a similar flavor wheel for e-liquids. And so here you see a flavor wheel on waterpipe tobacco products based on the EEST data, the European Common Entry Date data. A flavor wheel is often used for food products to give an overview of different categories of flavors, main categories, but also subcategories. Main category is at a higher level. Here we have 8 different main categories you see depicted over here: beverages, candy, flour, fruits, mints, spices, sweets, and other flavors. And you see beverages is subdivided in 3 different categories: coffee, tea, soft drinks, and alcoholic. And fruit is divided in 4 categories: berries, citrus, tropical, and other. The main categories of that specific examples are also given in the subcategories. There are 48 different subcategories. For example, when we look at the category other fruits, examples of that are apple, apricot, cherry, and grape. And apple is often used for waterpipe tobacco products. So as you will see here, the different subcategories are depicted equally large to give a good visual representation. What we did next was to make a similar presentation, but then you can also see the percentages of products in the different flavor categories. So then the outer categories are not equally large anymore, but instead their size depicts the percentage of products that are have been found in such a flavor category. First of all, note that all products that had been sent to the Dutch regulator were flavored, and no products were received without a tobacco flavor. Second, fruit is the most prevalent flavor category. 78% of all products had a fruit flavor. There were also a few prevalent subcategories with more than 10 products, blueberry, apple, strawberry, grape, bubblegum, watermelon, lemon, and mint. So I would say there is a flavor for every taste, which is of course exactly the problem when it comes to attractiveness. You see here mint as a main category, which means that it was the first flavor on the package, but often combinations of different flavors are found, and mint was also often found as a secondary flavor, for example, in the combination citrus mint. So mint, even though it was not the main category, is very often present in waterpipe tobacco products. Then we looked at the flavorings. There are many different flavorings, and here you see depicted the top 10 of the added flavors based on their prevalence of addition. You also see the medium concentration, the flavor description based on the Leffingwell database, and the smoke taste. What you see here is that the flavor description of the most popular ingredients is often related to a sweet description or has some elements of a fruit taste. So all these ingredients have fruit or sweet taste. We also depicted anatole, not because that's in the top 10, but that was present in high amounts. And it's also often studied in literature. Now, those top 10 flavorings and anatole, we also carried out chemical analysis for those flavorings. We extracted the products with ethanol and then carried out gas chromatography, mass spectrometry analysis on that. And we measured nicotine and 11 flavorings and identified and quantified them. We did it in waterpipe tobacco products, but also in herbal molasses and steam stones. We found that from those 11 flavorings based on waterpipe tobacco products registered, most of them were also present in the herbal products and in the steam stones. And we found that herbal molasses contained similar flavorings levels, but steam stones contained lower levels compared to waterpipe tobacco. We also found that anatole was present in high quantities in apple-flavored products, as previously reported in literature, that menthol as a flavoring was present in the majority of waterpipe tobacco products, and that waterpipe tobacco contained nicotine, but no nicotine was detected in the herbal molasses and in steam stones. So apparently, to our samples, no nicotine was added to the non-tobacco products. And currently, we are working on a manuscript on menthol and menthol-like compounds, because I said that's a very important flavoring and flavor in waterpipe tobacco products as well. So what does this mean for regulation? In 2021, the European Commission, in a report on the Tobacco Products Directive, expressed some concerns on use of waterpipe. They expressed concern on using shisha lounges, where consumers do not see health warning labels. There will be sessions on that topic tomorrow, I believe. But they also expressed their concern on the use of flavors and their attractiveness to youth. They also mentioned that the European waterpipe market is significant, especially among youth, and that risks related to waterpipe tobacco are often underestimated. And finally, they concluded that flavor use is strongly linked to waterpipe tobacco, and nice flavors was the term most frequently associated with these products. So apparently, flavors are an important aspect of waterpipe products. So this raises the question, whereas flavors in waterpipe products should be banned, as they already are in cigarettes and roll your own tobacco, and as in some countries, e-liquid flavors are regulated. Basically, there are two different ways to check compliance with the flavor ban. One is based on sensory properties of the products, so by smelling the flavor, or by smoking the product and then trying to taste the flavor and see whether there's any flavor other than tobacco present. Another way is based on additive composition by banning some or all flavorings. So I would like now to share some experiences based on regulation of cigarettes and roll your own, and later on e-liquids, because we can learn from that for water pipe regulation. So the European Union, as said, already forbids cigarettes and roll your own with characterizing flavors, which means a clearly noticeable smell or taste other than one of tobacco, resulting from an additive and noticeable before or during the consumption of the tobacco product. So also, if one opens a package and one smells a specific flavor other than tobacco, this is also banned. When regulations were in preparation, we were asked, we led a consortium to give advice to the European Commission on how to assess characterizing flavors in cigarettes and roll your own. So the advice was to use a combination of sensory profiling and chemical analysis. For the sensory profiling, to use an extensively trained expert panel. To start with smelling unburned tobacco first, because this is easier to carry out and has less ethical issues than to smoke products. To compare any product to a reference space of normal cigarettes, and to identify additives by headspace GCMS. Now, the European Commission took over the main parts of this advice. In 2017, an independent advisory panel was established to assess characterizing flavors in tobacco products. And this panel was assisted by a technical group of sensory and chemical assessors. They recently published a methodology combining results from an expert sensory panel with chemical assessments to verify which specific additives are responsible for the characterizing flavor. Now, as you see, it's a complicated interplay of different stakeholders. So the EHAP that gives an advice on the characterizing flavor, the technical group assisting them. EHAP can also use other sources. The Commission can request a consultation. The EHAP can give an opinion. Member states also have a role to play. So it's a complicated procedure. There are also some challenges, even when such products are regulated and checked for compliance. Even if all cigarettes would not contain flavors anymore, there's still the opportunity to use flavor accessories that can impart the flavor on tobacco. Here you see examples of products used for to flavor cigarettes, all with a menthol flavor, but they can also have many different other types of flavors. You see a spray here, drops, cards, stones, lid balls to use in your filter, and flavored filters. So there's many different opportunities to still impart the flavor on tobacco. When those are sold separately, they're not covered by the Tobacco Product Directive. We advise to implement additional legislation for that. Also because 13% of smoking respondents had started using such products since the flavor ban. And this is also important for waterpipe products, as many of you may know, because then so-called shisha syrup is widely available. It's marketed as that it can be used for stones and for tobacco. It's available in many different flavors. Now, and even if those can be regulated, what will happen if they're advertised as to be used as essence in your living room? So this complicates things. Then I would like to move on to the other case, e-liquid regulation. At RIVM, we did some research on the Dutch e-liquid market. So what we did first was to try to categorize all those different e-liquids in a way similar as I just showed you for waterpipe, but this was done a few years before waterpipe. So first we drafted the flavor wheel, in this case based on literature. Then we wanted to classify all the different e-liquids notified to the Dutch regulator by the EU SEC system in these different flavor categories. But first of all, note how many different e-liquids were notified to the Dutch regulator. almost 20,000, available in more than 200 unique flavors. So here they are classified according to the flavor wheel. Note that here there are some tobacco liquids, but still it's a minority with only 16%. The majority is other flavors such as mint, fruit, and dessert flavors. We also looked at the top 10 flavoring ingredients. If you have a very good memory, you may have noted that there is some overlap between this top 10 and the top 10 I just showed you for Waterpipe products. And also for the top 10 of most used e-liquid flavorings, you will also see that most of them have a sweet and fruity flavor description. We also carried out a chemical analysis on many different liquids and many different flavorings. Here you see depicted a heat map on the right-hand side. And when we performed cluster analysis on the ingredient profiles, we found 4 main clusters. And they can be qualitatively described as follows: as a cluster that is fresh, sweet in taste, warm sweet, so those are more the vanillin and caramel-like flavors, fresh cooling, those are menthol and citrus flavors, and non-sweet. Non-sweet contains tobacco, but also other non-sweet flavors such as, for example, whiskey and coffee. So now we know a lot about the chemical composition, and next we wanted to know how all these different flavors and flavorings are liked by users. First, we carried out a study of which I don't show data now, but then we assessed that when you ask people how they like a product, you will get a strong correlation when people smell the product or when people vape the product. So that means that smelling is a good proxy for actually vaping the product. So we started to do a large smelling study by adolescent non-smokers, young adult non-smokers, and adult smokers with many different flavors from all the different categories. Here you see depicted the liking, and here the different flavors. Now, there's a lot in this graph. First of all, we can see that the fresh sweet, warm sweet, and fresh cooling flavors are liked much better than the non-sweet flavors, such as tobacco, whiskey, and coffee. Second of all, the liking by the non-smokers, adolescent or young, is very similar to that by adult smokers. So liking of all these different flavors is rather alike for non-smokers and smokers. We found 2 exceptions, 2 tobacco flavors, an American blend and an Oriental that was liked better by adult smokers. But overall, as you see, youth was very much attracted to all those non-sweet flavors. So based on all this information and also other sources, the Dutch government decided to regulate flavorings and e-liquids. So they wanted to ban all flavors other than tobacco. And their means was by a restrictive list of flavorings that only have a tobacco flavor and can only impart a tobacco flavor on the liquid. There was immediate opposition by the e-cigarette manufacturers, but also the Action Committee for Vapors. This would translate as the tasteless regulation. And their argument was, well, you make the products very unattractive for people that would like to use an e-liquid for smokers to stop smoking. But the main policy aim of the Dutch government is to protect youth. Now, they asked us to propose such a list of flavorings. So we started out with all the tobacco liquids, which was around, at that time, 11% of all the different liquids. And in the tobacco liquids, we found 503 different flavorings. Some of them had the tobacco flavors, but it also contains compounds such as vanillin, which do not have a tobacco flavor, and with which also nice and sweet flavors can be made, to which young people are attracted. We had several criteria. It should be used, the flavoring, a minimal 0.5% of the e-liquids with tobacco flavor, because otherwise it's probably not that important. It should be used more often in tobacco liquids than in other liquids, because otherwise it's probably not related to tobacco flavor. No extracts of plants, because that doesn't have, that can vary in composition, which is very difficult for compliance purposes. The flavor description should be associated with tobacco and not with sweet or fruit. And the flavoring should not have health risk, because this is also forbidden by the Tobacco Product Directive. So we started with 503 flavorings, and after applying all those different criteria, we ended up with a list of 16 flavorings. And interestingly, with only those 16 flavorings, still 23% of the tobacco liquids in our original data set can be made. And manufacturers can also, of course, try out new recipes with these flavorings. So when this legislation will be implemented, the idea is that only liquids with a tobacco flavor can be made, and that e-liquids will become less attractive to young people. Here is the list of the 16, and as you will see in their flavor description, they mostly also have an element of tobacco or are otherwise related to tobacco. And now, what should all this mean for Waterpipe products? Can this inspire an approach for Waterpipe products? Well, I would say that it would be wise to ban all flavors other than tobacco when one wants to reduce the attractiveness, especially to young people. One can use a sensory panel here, but based on the experience from the European situation, one shouldn't make a procedure that makes it very complicated to have such a product tested by the panel. Another approach, and maybe they could even be combined, is to ban all flavorings other than tobacco flavor. And for Waterpipe tobacco products, that may mean no addition of flavorings. And for products such as herbal tobacco or steam stones, flavorings with a tobacco flavor could still be used. And it would be advised to have the ban in tobacco products, but also in related products such as herbal molasses and steam stones. Otherwise, people can use that as an alternative. That was my last slide. Let me go back and then share my screen.
Thank you, Dr. Talhout, for this rich presentation about flavorings, and there's a lot of documentation in the literature about how flavorings are attractive, particularly for Waterpipe tobacco users who are youth. This attractiveness of flavors has been documented in the various qualitative research studies. It's important to see that those products are available through a database that is registered, and that was an important aspect of the context that allowed to study those flavors. And I think it's a great example for other regions to see how we can develop such databases to have importers and regulate, and producers register those products so that we know what's out there in the market, and that we are able to study them systematically, and that was possible in the European region and in various countries in Europe. So that was a very valuable sort of framework to learn about. I'm going to open questions and answers through the chat again, because I want to give a chance to our next speaker, Dr. Rana Haidari, who has responded to a call for proposals, and the call for proposals was to actually see who's new and out there in doing studies around waterpipe tobacco use. She's in the University of Bourgogne, if I'm saying it right, in France, and the head of the Department of Health, Islamic Health Society in Lebanon. We have provided a forum and the conference for a shorter version of presentation to meet new colleagues and learn about new research that is happening in this field. So please go ahead, Dr. Haidari and present. Again, any questions to Dr. Talhout are welcome through the question and answer, and also directly, I'm sure, to her as a member for of the committees that are studying these products at the WHO level. You have the mic, Rano.
Good afternoon, ladies and gentlemen. Thank you, Dr. Rima. I would like to present our study, Smoking Status in SARS-CoV-2 Infection Severity Among Lebanese Adults, cross-sectional study. More than 1.2 million people have been infected, and approximately 10,000 have died from COVID-19 in Lebanon. As this virus spreads, more questions about COVID-19 disease severity risk factors arise. Observational studies have identified several risk factors, including age, gender, comorbidities, and smoking. Worldwide, the prevalence of smoking among male was higher than female worldwide in Lebanon. So, several research suggests a paradoxical link between smoking and becoming infected with SARS-CoV-2. Some authors postulate that nicotine would protect against COVID-19. Conversely, another studies show that smoking was found to be associated with increased morbidity and mortality in a variety of respiratory infections due to its immune response suppressive effect. Thus, it will be interesting to evaluate the prevalence of smoking and to clarify the association between smoking and COVID severity. The aims of our study were to evaluate the prevalence of smoking in the COVID-19 infection severity in a sample of adult patients diagnosed with COVID-19, and to explore the relationship between smoking and SARS-CoV-2 infection severity. An observational retrospective analytical study was conducted on patients diagnosed with COVID-19 at the Islamic Health Society between December 2020 and April 2021. Adult patients aged more than 18 and who tested positive for SARS-CoV-2 by PCR were eligible. Participants were contacted via phone by Corona Call Center, and the study was approved by the protocol of the study was approved by the Islamic Health Society Research Ethics. The main outcomes were presented as follows. Smoking status was defined as never smoked and current smokers. To explore the dose response effect, a variable by collecting data on smoking status and smoking duration in years was created as follows. Current tobacco smokers for cigarette and water pipe grouped with mild, moderate, and heavy according to number of cigarettes per day or number of water pipe per week, and duration of smoking. Patients with COVID-19 were classified into 3 levels: asymptomatic, mild, and moderate and severe, according to symptom and the presence of pneumonia or not. Sociodemographic and the clinical characteristics of the participants were described. A bivariate multinomial logistic regression models, overall and split by gender, were conducted to explore the association between smoking status and dosages and SARS-CoV-2 infection severity. This table shows the demographic and the clinical characteristics of the COVID-19 patients as per their smoking status. A total of 900 confirmed COVID-19 cases, of whom half of the participants were females. 57 were current smokers, and smokers were more likely to be males and to have a lower mean age as compared to non-smokers. Comorbidities among smokers were higher than among non-smokers. This table This table shows adjusted OR from multinomial logistic regression with the severity groups as the dependent variable, asymptomatic group as reference, and the smoking status and dosages as independent variables. A significant association was found among male with mild infection compared to their asymptomatic counterparts, OR 1.78. Waterpipe smoking was found to be associated with infection severity among male with mild infection, OR 2.64, and severe infection, OR 2.79, compared to their asymptomatic counterparts. Regarding waterpipe dose-response relationship, moderate dose consumption was associated with infection severity among male with severe infection compared to their asymptomatic counterparts, OR 2.40. In our sample, sample, smoking prevalence was higher than WHO 42.6 in 2018, as well as the prevalence of tobacco smoking reporting among the hospitalized COVID-19 patients of Khalil et al. Study, 42. Our findings show that male patients present severe infection more than female. Based on previous studies, evidence suggests that male patients are the most susceptible to SARS-CoV-2 infection, which is supported by our data. This sex difference may be related to several factors such as activity of the immune system and its modulation by sex hormones, coagulation pattern, and pre-existing cardiovascular disease. More research on the potential gender disparity in the effect of smoking on COVID-19 severity while accounting for smoking dosages are still needed. And our results, our results suggest adding tobacco smoking, particularly waterpipe, as a risk factor for worse COVID-19 prognosis among males, and highlight the importance of waterpipe smoking cessation. In conclusion, there is a growing need to support the WHO statement that smokers are at high risk of developing severe disease and death, and the battle against smoking should continue. Smoking cessation should be incorporated into public health campaigns, especially during the SARS-CoV-2 pandemic. Future studies should take into consideration social factors that affect smoking, participation in waterpipe smoking at the same time. And that's all. Thank you.
Thank you, Rana, for presenting this valuable single study that is much needed to add to the evidence around this topic. And thank you for for keeping time.
Thank you.
I will close today and looking forward for tomorrow. Of course, the importance of this forum is highlighting what we know, but also highlighting what we don't know. I mean, how else will we be able to identify research gaps and think about what evidence we still need to be generating to identify and to address potential regulations and policies and evaluate effectiveness of policies. It's an excellent set of presentations that prepares us to the next round of presentations that is going to happen tomorrow. The presentations first highlighted here the need to maintain surveillance of waterpipe tobacco smoking. So we should always stay vigilant. We need to monitor at country level, and highlighted the role of WHO in supporting resources and supporting technically countries, continuing to do the Global Youth Tobacco Survey and the GATT survey and validating findings across countries to understand more about maybe reasons for underreporting and think about innovative ways to address them. The presentations also confirmed the global spread. So this is still not an issue only for the EMRO region, but also waterpipe tobacco smoking is an issue around the world. And so it remains a priority for the WHO, and the Knowledge Hub is a case in point. It's a global hub that is focused on waterpipe tobacco use. Flavoring, access, affordability, and misinformation, the spread of misinformation through social media were raised across various presentations, and those being drivers of youth among youth, all require addressing in regulations. More importantly, understanding the particularity of waterpipe tobacco use and how we can address evaluations and ensure effectiveness of the policies that are produced. And then, of course, the focus on COVID-19. We cannot speak about tobacco use without addressing COVID use, and we need to continue building our understanding. The coronavirus is not gone, and it will continue, and we need to build this evidence around it through systematic reviews that bring in and summarize what single studies are telling us, examples in countries that we heard about here, specifically from single studies in Lebanon and Iran. It is important to highlight and support low resource setting to produce those studies, so that the knowledge that we're building, the summaries that we're making in those systematic reviews are reflecting all countries in the region, and not countries that have resources and are available to document this research, do it, and publish it. I want to thank all of you for attending today, and urge you to continue with us on this platform tomorrow. I also want to urge everyone to, if there are any questions right now, we actually have an opportunity for a question or two. I can wait to see if any of the participants might have any questions, and if not, I want to encourage you to put them through Q&A, or even if you think about the question beyond the timeline of the conference, you can email it to us as organizers, and we can connect you with participants that might have more time to come to answer your questions. I'm looking at the list of participants to see if
there is a question to Rana.
okay, great. It's on the Q&A.
Yeah.
Okay, yeah, I see 3 now here. Perfect. So I do not see the questions and answers. If you can.
Yeah, there's a question to Rana about thanks for your presentation. How did you define light, moderate, and heavy waterpipe smoking?
So it now, yeah.
Yeah. Okay.
Oops.
Okay. We classified your question. It's about the classification of patients with the COVID-19 or the dose response effect. For the dose response effect for the cigarette smokers, mild, it's lower than 10 cigarettes per day for 15 years. Moderate, lower than 10 cigarettes per day for 50 years, or more than 10 cigarettes per day for 50 years. And according to Waterpipe, mild, moderate, and heavy were classified according to number of waterpipe per week and the duration of smoking per year. For the classification of patients with COVID-19, asymptomatic infection, there was absence of SARS-CoV-2 symptoms. Mild infection presents at least one SARS-CoV-2 symptoms, excluding pneumonia. Moderate to severe infection, presence of pneumonia, and or hospitalization for COVID-19.
Thank you, Rana.
Thank you.
Any other questions that you see, Dr. Zatari?
No, this is the only one. I see there are other comments pertaining to the earlier presentations, but not to this one. As there was just comments made.
Right, yes.
Rather than being a question, but this is the only question that I see.
Okay. Do you have any announcements to make in the closing?
No, just wanted to thank again all the speakers. Thank you for moderating this session. I think this was an informative day. Please make your notes. We would appreciate your evaluation later on when we're at the conclusion of the symposium, and also and for you to get obtain your certification of attendance. This is day one. This was very informative. And I'm looking forward for you to join us tomorrow and after tomorrow, same time, same channel. So looking forward to seeing you and take part in these discussions. So long and see you tomorrow.
Thank you, everyone. Bye-bye.
Bye.